This is a great case review that I call Repatha or no Repatha. And the reason why it's a great case is that because it's exceedingly common. In this case, we are dealing with 51-year-old woman who presents with a family history of known coronary artery disease. What essentially has happened is that her father passed away from a fatal myocardial infarction at the age of 62. So it wasn't really the age of 60, which is what the scores want us to use, or less than 55. So technically, she doesn't meet the criteria, but it comes pretty close. She is normotensive and, of course, dyslipidemic. Now, looking at her lipids, you could see that this does not appear to be cardiometabolic. It is most likely consistent with polygenic dyslipidemia. And of course, a concerning factor is the significant elevation of lipoprotein(a). Based on these parameters, we certainly want to know the imaging. Now, her imaging is excellent. She had a coronary artery calcium score of 0 just a few years ago in 2022, and certainly her risk percentile will be very low. And she has not had CIMT, so we really don't know what that is. Now, genetically, we are concerned that she will be at high risk for lipoprotein(a). And of course, her current genetic profile is pending. We don't know her polygenic risk scores yet, or any other mitigating genetic factors that potentially could increase her risk. Using prevent estimates, we have entered her zip code where she is in a moderate deprivation index area. She's currently not actually on any of these medications, but concern that she has is that Repatha has been prescribed, has been approved, she has ordered it, but she's hesitant to actually use it. So how do we help a patient like this to make a decision? And this is what makes this case interesting, because it's bread and butter, right? It illustrates to us how we can use Heartwell.AI to assist our patients and ourselves to arrive at patient-shared decision-making. So if we go to the results, and we'll chat with the case in a few minutes, and I'm going to go ahead and just uncheck the lipoprotein(a) risk enhancement and genetic risk adjustment, you could see that the traditional deterministic, not probabilistic, but deterministic computation using PREVENT, which is currently endorsed in the most recent edition of the guidelines, as well as other scores for risk estimates, this patient is in a low risk category. Of course, her lifetime risk, as is the case with most circumstances, is elevated, and this is very common. That what would happen if we were to deterministically apply her lipoprotein(a) as well as her pathway specific genetic scores. Remember that at the age of 51, the standard risk scores tend to underestimate disease burden with regard to the future. While they're giving us a fairly reasonable 10-year estimate, they become a little bit fuzzier over the course of a person's lifetime. So when we do apply her lipoprotein(a), you could see that there's a 60% jump in her risk scores. And when we do factor in and take a look at the lifetime risk here, it's now becoming went just from 39 to 62. And if we use genetic adjustment based on what we know now, you could see that she actually had transitioned into what the current guidelines call an intermediate score based on PREVENT, any score worse than 5%. And certainly her 30-year disease risk and lifetime disease risk, especially lifetime risk, are fairly high. So should this patient be on Repatha? Let's go ahead and we're going to do our modeling so that we can decide on Repatha versus alternative treatment. So I'm going to go ahead and pick Repatha here from the list. And you could see this therapy selection is very powerful. It essentially uses her PREVENT risk score to show you that it will drop away from that 5% zone where interventions are warranted. Although we don't have a lot of data on using Repatha for primary prevention. And here it would be primary prevention because patient's coronary artery calcium score is 0. She has no identifiable atherosclerotic disease based on the tests completed so far. Now, obviously, it's been 4 years years since her calcium score, if we re-image her now and or decide to proceed to CIMT, we may end up in a different situation. But this is based on the information that we currently have. Now, you could see that with the use of Repatha, we have approximately a 60% anticipated drop in some of the very important parameters, her LDL-C, her ApoB, and potentially lipoprotein(a), although Repatha is not universally achieving this in every single patient. And so the combined effect of this will be a 36% reduction in her risk, putting her indeed in the low risk category. So it is a powerful intervention. And if we want to describe a little bit more about her results, we can go ahead and generate a summary. And we can certainly go ahead and save this simulation so that we can return to it and show to our patient what indeed we can accomplish. While it's generating a summary, I'm actually going to chat with the case. And so I'm going to ask a question that the answer that I'm sure you want to know is that we're going to say what data exists to support using Repatha in primary prevention for a patient with CAC of 0 and elevated lipoprotein(a), right? So we're going to try to describe this patient. Basically, these are sort of very good hard pieces of data that we could provide. And so let's see what AI search is able to tell us. And so, as I mentioned, the reason why I picked this case, because this is a common clinical dilemma. And so here's the situation: the power of coronary calcium score of 0 versus lipoprotein(a) risk, right? We know, and this is a super, super recent study, is that the elevations of lipoprotein(a) are more significant with regard to risk for people whose CAC isn't 0, right? And we don't know if she transitioned from 0 to a non-zero score. So, and as I mentioned to this patient, and in case I didn't know the most up-to-date literature and wanted the confirmation, we don't have any trials supporting Repatha for primary prevention in a population of patients whose coronary calcium scores are 0. And even the ongoing trials, such as Vesalius, for example, and Odyssey outcomes sub-analysis, are not quite a good fit for this patient. Now, we have already modeled the risk of what we can to do here with regard to using Repatha, how much it will work with regard to LDL-C and ApoB reductions. And you could see it could take her in a much safer range than with right now. But remember, this is not really an lipoprotein(a) lowering drugs. And so here we need to kind of make up. So I prefer actually a different approach, and this is what I suggested to this patient: Berberine and Bergamot and moderate intensity statin, or what we call what falls within the ALARA approach, as low as reasonably achievable. So let's see how our AI clinical assistant will respond to that, if it's able to give us some useful information. And you could see that utilizing, so this is what I'm thinking of, and this is the trial evidence now. AI search is helping me to make up my mind, right? The clinical evidence regarding this combination, moderate intensity statin, usually will not lower Lp(a), but there is no significant, or we don't necessarily know that Repatha will. There could be some bump, that is true. But using this combination, we could expect up to 50% LDL-C ApoB reduction. And we have Berberine, which is acts via mechanisms similar to PCSK9 inhibitor, and also has some synergy with the statin, as well as Bergamot, that in addition to its lipid lowering effect, has cardiometabolic effects and also has polyphenols. And you could see here that the expected combined effect will be similar, not exactly, as powerful as Repatha, but, but fairly significant. What's interesting is that AI also warns us, about lipoprotein(a) trap, right? So they need to really push down to the LDL-C and the ApoB targets to a very aggressive range. And while we should be able to do this with ALARA, Repatha may potentially be a little bit more powerful in that regard, or we may decide, escalating her statin, for example. And potentially when the new medications for lipoprotein(a) come about, she may benefit from those. Now you could see that this is the Repatha summary that's already been generated, something that you can share with the patient that brings in all of the information that we need, that we can provide the results into the patient. Now here, however, now I'm going to go ahead and I'm going to do something different. I'm actually going to model what we've just discussed a little bit. So I'm going to give her a little bit of Bergamot and increase her dose, and I'm going to give her some Berberine. So this is sort of this more natural approach. And I'm going to go ahead and give her moderate intensity statin, which is Rosuvastatin 5 milligrams. Most people tolerate it just fine. And you could see that we are actually in a very comparable zone to Repatha. Now, obviously, this is a deterministic calculation. We don't know with 100% certainty that she will achieve these targets, but these are pretty close, and she could potentially gain additional reduction, 10 to 20% from nutritional modification and some visceral weight loss. So, so this isn't an unreasonable approach. And with regard to lipoprotein(a), it remains to be seen. We can go ahead and save it as a second simulation that we can share with our patients. So this is different than Repatha, and go ahead and regenerate the summary so that the patient now has information on Berberine and Bergamot and a low intensity, moderate intensity statin, which is Rosuvastatin 5 milligrams actually is. And so this is an alternative for this patient who is hesitant to use Repatha. So you could see there is definitely an opportunity now in different ways to help this patient to understand cardiovascular risk reduction, both short-term and long-term, and to engage with us in choosing a route that she prefers. Obviously, the route that has to do with supplements and diet is more integratively aligned than the route that potentially only involves Repatha. It certainly gives us an opportunity to get a patient in a different, sort of more comprehensive alignment check, for oxidative stress, check for inflammation, rebalance her hormones. And you could see here that this is now the AI summary that is basically giving us an estimate of where she is at. And you can share it with the patient because it explains what we have chosen as our agents, explains the medications, explains the supplements, gives us a handle on drug interactions, and so on and so forth. And obviously this data could change if more information comes in. For example, if we do advanced biomarkers, if we do additional genetic scores, or even CIMT, reimage her calcium and see if she shifted from a calcium of 0 to a non-zero calcium score, we could potentially redefine this. But this is dynamic, and this is in the moment, allows you and your patients to settle on the strategy that is most aligned with their wishes in regard to their cardiovascular risk management.